take a little bit of an intro, step back a little bit from the detail of registries and just, I think, go through a little bit of commission things. And at the Australian Commission on Safe and Controlling Healthcare, so we work for all governments and our budget comes from each state and territory as well as from the feds. The joys of working the jurisdiction. But we take the view, and we've taken it for a long time, and it is based on pretty good research, that good quality data fed back to the provider level, coupled with interventions based on that feedback, which sounds very much like your NHMRC Better Health Initiatives grant, Dom, does improve the quality of care. And we also understand, in spite of a whole load of folk working very hard, that the appropriateness of care for given conditions isn't always as good as it could be, and the outcomes of care for given conditions across the country isn't always as good as it could be. Research is a part of that, understanding genes and stickiness and clots, but also actually how can we bring most providers closer to recommended care. That will save lives, and that in itself, health services research, I think has got a lot of yield ahead of it. So look, we do take the view that the use of data locally is important. And I'm not sure if you do know, but now each state and territory is requiring hospitals to be accredited against safety and quality health service standard. That's been a very interesting journey for me. I wasn't involved in the setup. But accreditation's been a very interesting industry, a bit of a cottage industry, and now each state and territory's put at its core 10 standards against which hospitals, public and private, will be accredited. And that sounds like fun, except one of them actually says that, and hospitals are being accredited against this now, are regular reports on indicators reviewed by the executive level of governance, and is action taken? Look, it's a hard thing to say yes or no to, but at least a line is drawn in the sand. It's no longer enough to just say, well, we're submitting data. So we know there's been a number of studies that show a correlation between feedback of data and improved outcomes. This is Ontario. Their C. diff rates started to go down when there was more regular reporting. Those of us who are frequent flyers in registry world know all about the Swedish registries, and once you start feeding back a whole load of things, results do get better. This is a British study on the correlation between adherence to recommended care guidelines and outcomes, mortality and readmission. And I know you'll like a good graph, and you know the red dotted line is the one you don't want to be on. Although there's quite a complicated story under this, folk who follow the guidelines, their patients do better. That'll come as no surprise to you. Okay. So taking that and taking the fact that we're not starting at the beginning here, the stroke group is one of the groups we really enjoy working with, and I'm going to tell you why in a minute. But you're sort of well down the path. You have a national consensus around what good looks like. I think you've got the right blend of collecting a small amount of data routinely and doing those magnificent audits intermittently that give you some of the structure things and also a bit of drill down and detail. And I'd like to, I guess, thank Oscar and the foundation, because we used your data last year in our annual report. We reconfigured that into charts, which is a way we like to present sort of lots of measures, and all of them went from left to right up. So we could see that there was improved compliance with recommended care and outcomes over time in Australia, and I think you guys have got a lot to do with that. Before I go too much further down the registries path, I just wanted to sort of remind folk where we are, and it is really hard working in a federation from a health data point of view. So when you go to England, you look at Dr. Foster and NHS, and all the hospitals put their data in a box. There seems to be a unique identifier, and reports come out quarterly, and there's 9 million separations a quarter going, not 9 million a year. And, clever people at the Imperial College do risk adjustment, and it's all good. And a couple of things that come out of that, which won't surprise any of you, is that when they reduced the number of hospitals who would take stroke patients in London, less people died. In other non-stroke areas, discharging people from ICU at night is not really good. Those of us working in hospital at night know why that happens. And more people die on weekends. There's a whole lot of stuff out there that we know, and getting to use that is really hard. Now in Australia, I guess what I would see officially where we've been at in terms of data is a lot of, because data's held and owned by the states, and then there's the private sector, which is a third of activity, probably less than that for stroke. So it's complex, and then to put it all in a box and start making sense of it, it's very laggy. So typically the official data from hospitals goes to the Institute of Health and Welfare 5 years after the close of the financial year. That's not the Institute's fault, that's the way federations work. It's de-identified, so we can't actually link deaths down the track or readmissions and things like that. So it's very much a focus on descriptors, which I don't think is helping us get to where we want, which is understanding which hospitals or units aren't achieving what the best ones are doing, so you can sort of start to offer them some support. I think although people got excited about the reform agenda, and you've got a National Health Performance Authority, you've got the Commission now being a permanent one, the language of performance is still stronger than the language of quality, and I myself am not really happy about that. And I think we need to go through a phase of helping people understand quality before we get to performance. And the biggest one I think Oscar and everyone faces is at the moment, if we want to collect some data that we can do good things with, i.e. look at readmissions, look at 6-month outcomes, there is the requirement in many places to get a hospital ethics committee approval, or occasionally a whole of jurisdiction one. That's a big effort. I think the safeguards are good. I think it's very helpful to write a NEEF. It makes you articulate your plan. But to do it 800 times, I don't think is the best use of anyone's time. So the work we've been doing, although we've done a lot of technical work on standards, which I won't go into today for registries, a couple of things we learned working with registries was there is a right way to build them. The right way to build it is to build a national box. It's extremely efficient. As with our bank accounts now, you can give each state and territory its own view and say no one else can see your data until you say so, so there's no need to build 8 boxes. That, of course, brings with it the benefit of putting the same shaped data in. And you need to also, I guess, take into account places like Tassie and ACT and NT, that if you've only got 1 or 2 hospitals, even if you're collecting the indicators and looking at it, it doesn't really tell you much until you can see how comparable hospitals are doing on risk-adjusted outcomes. So seeing how comparable hospitals is going, move my dot, looking at funnel plots, that really is about having national data in a box so you can see where you are against comparable units. That's really important, and then being able to respond to that. So the efficiencies as well are there. So we kind of know what that looks like, and for what it's worth, although we haven't published it, we think the right way to build a registry is to be operated by expert centres, and Monash is one, and there may be others. I think the George Institute's pretty good at it now, the Institute of Health and Welfare are probably pretty good at it too. If they support 6 to 10 registries, and that doesn't mean all of the clever people, all the DOMs and the TASHs have to go and sit at that place. They then run it with their own clinical governance. I think the right thing to do is to have buy-in from the states and territories to make your whole life easier once you've got it. It's about $900,000 to run a state-of-the-art registry with shared infrastructure, about $930,000 a year, with a data set that's probably got 25 items in it, with a couple, and that means you've got someone who runs the registry, you've got an epidemiologist or part of one, you've got those people who polish the data and chase up outlier data and look at the data quality. I think that's a magnificent buy when we know how much we spend on registries, but that was quite an interesting find. The barriers that we were stuck with, I think, at the end of that, and we're taking some work to health ministers this year on national arrangements, is really to get beyond different data sets around the country but still make use of innovation coming bottom up, and to, in particular, to have an agreement, perhaps with Ramsay or HealthScope for all their hospitals, or New South Wales, Victoria, Queensland for all their hospitals, that look, this is a good thing, there's a lot of security in place, here's how we take care of your data. Are you happy to authorise this as a data collection which you support and that you can have access to? I really think that's the answer. I know there's a few hairs on that. So we're not at the end of our journey yet. We know what good looks like technically. We know what good looks like in terms of governance. That means clinicians interpret the results, but I think you do have to partner with people who run health services. We think that amount of money is probably realistic for well-designed registries. We triangulated that here and in the UK. And that makes one big assumption, of course, which means that the data comes in from the hospitals. And that's the obvious trade-off between a succinct data set which is achievable, and a wonderfully delicious long complex one, which we know just doesn't happen. So that's there. I'm going to wrap up now because Chris has got a lot of us to get through. The opportunities at the moment, I think, is that clinicians are now highly numerate and statistically schooled. It's a different world to 30 years ago. It seems normal that folk want to measure. They're a little bit competitive. You don't have to ask them. The science of registries is a lot better known now. I think there is now a basis for national collaboration. People are getting used to that. And I also think the environment for data linkage is changing. Look, I think the technology of data linkage is not complicated. We did some work a couple of years ago. Look, BioGrid just down the road, they're all over it. It actually isn't very expensive. So that's Victoria. You know, CSR in Queensland, they built a rival engine. Again, not complicated, not very expensive. And there's another one I know less about, but sure, which seems to be a collaborative of different places, including, I see, the Victorian government. That's not the hard bit. I think the hard bit is providing guarantees to states and territories and private loss ownership group that their data is secure and can be well used, and that they will get something back. If I was trying to convince the next hospital to bundle onto my registry, I wouldn't say, can we collect data? I'd say, would you like every 3 months these 12 graphs of your risk adjusted against your peers? Because that's what they're going to be buying. And I think that's a wonderful thing, and you can't do that on your own. I won't talk much more about registries, except that we think Oscar's a really good example and pretty much ticking most of the boxes, and we've had a lot of help from them. One of the reasons the Commission particularly likes working with this group is because there is a good sort of national collaboration between clinicians, researchers, foundations, and of course stroke care consumers or their relatives. The guidelines, although we can always play with them, are actually pretty clear. We know what good looks like and we know it improves outcomes. And stroke's that classic one where really a registry would look at a team's quality of care, wouldn't it? It's not like this is the surgeon, rest doesn't matter. Rehab's an important bit, early care, ambulance, ED. So it's a pretty good place to work, and of course there's a lot of improvement ahead of us.